We're now in section 6 of chapter 7 on the skeletal system. We're going to talk about regulating blood calcium levels. Learning objectives for this section are to be able to explain the activation of vitamin D to calcitriol, discuss the release of parathyroid hormone, explain how parathyroid hormone and calcitriol function together to regulate blood calcium levels, and discuss homeostatic system involving the hormone calcitonin and its effect on blood calcium levels. Also to be able to explain, sorry, I repeated it there. I thought I went forward and I didn't. Regulating the calcium concentration in blood is essential, of course. Calcium is required for initiation of muscle contraction, exocytosis of molecules from cells, including the neurons, stimulation of the heart by pacemaker cells, and blood clotting. Quite a few primary functions for calcium. That's probably not terribly surprising how important calcium is. Two primary hormones that regulate blood calcium are calcitriol and the parathyroid hormone. The activation of vitamin D to calcitriol, specifically UV light, converts 7-dehydrocholesterol to vitamin D3, and vitamin D3 is cholecalciferol. It's released into the blood. It's absorbed from the small intestine from the diet. At least that's where it's ideally obtained from. Vitamin D3 then circulates throughout the body. It's converted to calcitiol by the liver enzymes. In both steps 1 and 2, both these occur continuously with limited regulation. Calcitiol circulates in the blood. It's converted to calcitriol by kidney enzymes. And the parathyroid hormone increases the rate so that more calcitriol is formed. And the calcitriol stimulates the absorption of calcium ions from the small intestines into the blood. So taking a look here. Sun, given our UV light, predominantly UVA and a little bit of UVB, and our precursor molecule, the 7-dehydrocholesterol, is involved along with that UV light. The precursor molecule is converted to vitamin D3, cholecalciferol. And then and also you can get obviously calcium from, and vitamin D, I should say, from milk. Not to be confused with necessarily calcium, because your body has a hard time getting proper calcium levels from milk. That's a whole different level of discussion of topics with nutrition related to physiology. But we don't, just because your dietary substance you take in says blank milligrams or micrograms or IUs or whatnot of something, doesn't necessarily mean that's what your body makes use of, right? That being said, so vitamin D can also be obtained from milk or some other substances as well. Vitamin D3 is converted into calcitiol in the liver when an OH, a hydroxide group, is added. And then calcitiol is converted to calcitriol in the kidney when another hydroxide group is added. Becomes calcitriol. The parathyroid hormone is secreted and released by the parathyroid glands in response to reduced blood calcium levels. That's the primary job. It accelerates the conversion of calcitriol to calcitriol by the kidney. And then the PTH and the calcitriol interact with major organs. With bone, interact intersynergistically to increase the release of calcium from the bone in the blood by increasing osteoclast activity. In the kidneys, it stimulates the kidney to excrete less calcium in urine and increase calcium reabsorption. And then the small intestine, only calcitriol increases absorption of calcium from the small intestine into the blood. So, of our stimulus, well, we got low blood calcium, all right. Parathyroid gland detects low blood calcium levels, secretes the parathyroid hormone, and then with calcitriol here, the vitamin D3 is converted to calcitiol, then calcitriol, and then calcitriol is released from the kidneys, and then it increases the absorption of calcium from the small intestine, and then PTH and calcitriol act synergistically to decrease calcium excreted in the urine. Kidneys being responsible for waste, right, managing that. And then bone, parathyroid hormone and calcitriol act synergistically to increase the activity of the osteoclasts. And blood calcium levels then, with homeostasis, blood calcium levels rise and return to a normal homeostatic range. At least that's how we want it all to happen. A clinical view for a disease like Rickets. It's a disease that's caused by a vitamin D deficiency in childhood. It's characterized by deficient calcification of osteoid tissue. Obviously, getting enough proper sunlight would play some role with that. Genetics, once again, will play a role as well. Can create a bow-legged appearance, and then there's also naturally disturbances in growth, hypocalcemia, and tetany, which results in cramps and twitches. It's caused by low blood calcium. It occurs in some developing nations where it's a greater issue with nutrition predominantly, along with not necessarily sun exposure per se, but genetics and related to nutrition play a big role with that as well, let alone based upon activity, numerous factors there. The incidence is increasing in urban U.S. children, seeing more and more of this. Calcitonin aids in regulating blood calcium levels. It plays a less significant role than PTH or calcitriol. It's released from the thyroid gland, as opposed to parathyroid gland here for the parathyroid hormone, in response to high blood calcium levels, opposed to low, right? It's also secreted in response to exercise. It inhibits osteoclast activity in the bone, and it stimulates kidneys to increase loss of calcium in the urine. It reduces blood calcium levels. The greatest effect is during the greatest bone turnover in growing children. So, what did you learn? What organs are involved in activating vitamin D3 to calcitriol? Should be able to answer that now. When are the parathyroid hormone and calcitriol produced and are secreted, and what organs respond to them? And how does calcitonin regulate blood calcium levels? And we'll go and talk about our final section here, the effects of aging, describing how aging influences bone structure. There are two ways essentially aging affects bone: decreased tensile strength of bone and the bone loss of calcium and other minerals. With the decreased tensile strength of bone, there's a reduced rate of protein synthesis by the osteoblasts. The relative amount of inorganic material increases. Bones become brittle and susceptible to fracture as we age. That can be dramatically reduced, by the way, by up to 50% or more potentially by engaging in proper physiological behaviors, specifically with exercise, nutrition playing a role as well, but secondary. You could argue they both are necessary, of course. Bone loss of calcium and other minerals, bones become thinner and weaker, and insufficient ossification is a result, known as osteopenia. Okay. Now, osteopenia occurs slightly in all people with age. Usually begins around age 35 to 40, generally speaking, somewhere in there about middle age, early middle age. Osteoblast activity declines. Osteoclast activity is now at previous levels. Vertebrae, jaw bones, epiphyses either lose large amount of mass, and women lose again there, how that happened, lose more of their skeletal mass every decade than men. Okay, it's mostly due more with different hormonal differences between women and men, and a lot of that can be alleviated. Once again, a lot of those numbers tend to level out between men and women when women, unlike in many decades past, in the not too recent past, when it was less likely to see women engaging in exercise, sport, and whatnot, whereas the last 20, 30, 40 years seen a huge increase in the level of activity, women on par with men as far as regular activity. That played a big role in also helping hormonal balance as well, which also plays a role then with bone and not having such significant bone loss, at least at an early age. Osteoporosis is reduced bone mass that's sufficient to compromise normal function. It occurs in a significant percentage of older women and occurs in a smaller percentage of older men. Reduced hormones with age are the result here. It's obviously more significant than osteopenia. It's reduced, and we're talking here now with vitamin D, growth hormone, estrogen, and testosterone all playing a role, and their decline playing a role with osteoporosis. And this, of course, contributes to reduction in bone mass. And the most significant factor, unquestionably, is the level of activity. You can't keep yourself from aging biologically, but you can reduce some of its effects to some extent. Osteoporosis, again, results in decreased bone mass, weakened bones, prone to fracture. It's often linked to age, onset of menopause, smoking history, Caucasian race, and I can't believe the book didn't mention it. I didn't put it on here because the book didn't note it, but exercise. Okay? Postmenopausal women are most at risk. Their increased incidence of fracture course is much higher, especially at the wrist, hip, and vertebral column. And the spine, that's a major one. That's why it's so important to get compressive forces from a general perspective. Walking being the most important activity for a human being, really, especially as we age. I will say from an athletic perspective, me being a coach, or at least former coach, don't coach as much anymore, I have a hard time with seeing an older individual spending so much time in the pool and not enough time on land, because they're not going to get compressive force activity they need for strengthening the bone and avoiding issues like osteoporosis and reducing the effects of osteopenia. With regular compressive force activity. They have to go for a crazy run and lift heavy weights, but they got to do something. The best treatment is prevention with the diet and more physical activity. I should say physical activity and then diet. Diet's not the predominant. Physical activity is the predominant here in young adults. Medical treatments involve slowing the rate of bone loss and attempting to stimulate new bone growth. But this is the most important one. No question about it. So, you should be able to explain why women are more likely than men to develop osteoporosis after that section with aging. I also explain the 4 steps by which fractures heal as we move into our final section here with bone fracture and repair, which is a very brief section here. Fractures, breaks in bone. Types of fractures, we have a stress fracture. It's a thin break caused by increased physical activity. A pathologic fracture, which occurs in the bone weakened by disease. A simple fracture, it's a broken bone, but it's not penetrating the skin. And a compound fracture is when one or both ends of the bone pierce overlying skin. And hopefully, remember this happened to you, and it's a bit of an interesting sight when it does happen. It hasn't happened to me, but I've seen athletes have it be the case, and it's obviously a much more difficult fracture to recover from. But like all injuries, there is recovery, at least ideally, if things go well. Now, all of these here are, we won't go over them in full detail. Text where you get a lot of these, but you should be able to understand the basic concepts here, the classifications of bone fractions from a general perspective. You're not going to get multiple choice questions on all of these, but some of these are pretty straightforward. Okay. Generally speaking, I'm just going to go over them real quick. An avulsion is a complete severing of the body part, typically a toe or finger. Colles is a fracture of the distal end of the little lateral forearm bone, like the radius, produces a dinner fork deformity. Pretty scary stuff. Comminuted is when the bone is splintered into several small pieces between the main parts. Complete, the bone is broken into 2 or more pieces. Well, that you should know. Compound, you should know. Broken ends of the bone protrude through the skin. Compression fracture, bones is squashed, which is occur in a vertebrae during a fall, which is obviously a pretty serious fracture. Depressed, broken part of the bone forms a concavity, as in skull fracture. Okay. Displaced, fractured bone parts out of an anatomic alignment. Epiphyseal, you'll need to know this one. The epiphysis is separated from the diaphysis at the epiphyseal plate. Green stick, partial fracture, one side of the bone breaks, the other side's bent. Hairline, you've probably heard this one many times before. There's a fine crack which sections of the bone remain aligned. It's common in the skull, although hairline fractures can occur throughout the body. Impacted, one fragment of the bone is firmly driven into the other. Incomplete, the partial fracture extends the path only partway across the bone. Linear fracture is when it's parallel to the long axis of the bone. Oblique is a diagonal fracture at an angle. Pathologic is weakening of a bone caused by disease process. You should know that one. Pot is the fractures at the distal ends of the tibia and the fibula. Simple or closed, the bone doesn't break through the skin. Spiral, the fracture spirals around the axis of longer bone, resulting from twisting stress or torsion. That one you should know. From a very basic standpoint, makes sense, right? That torsion. Stress fracture in general, this you definitely should know too. When thin fractures are due to repeated stressful impacts, such as running, should say it's not such as running, such as improper running. As a running coach, I have a hard time with that. Such a common thing that people come up with. It's running that did it. No, it's how you run. And if you run with poor form, I've never known anyone with great form when they run to have an issue. If they overrun, what happens? They get tired, they don't run well, and they repeatedly can run with bad form. Guess what you're going to end up with? Probability of something down the road is a stress fracture. These fractions often are very difficult to see on x-rays, and a bone scan may be necessary to accurately identify their presence. Transverse fracture is at the right angles to the long axis of the bone. Fracture healing, simple fractures 2 to 3 months to heal. Compounds can be much longer. In reality, whenever it talks about healing doesn't mean it may be healed, doesn't mean it can be without pain or some dysfunction. We don't want to confuse healing with normal function. That can often double relative to the amount of time for healing versus normal function return. Okay, doesn't mean it will, but it can. That's important to note. 4 steps of fracture repair. Fracture hematoma forms from clotted blood. The blood vessels are torn within the periosteum. Fibrocartilaginous callus forms. The fracture hematoma is reorganized into a connective tissue procallus. Fibroblasts produce collagen fibers. Chondroblasts form dense, regular connective tissue. And the procallus becomes fibrocartilaginous or soft callus. And then the hard bony callus forms. Osteoblasts adjacent to the callus produce trabeculae, and that replaces the callus. This forms a hard bony callus, and that continues to grow and thicken. And then bones remodeled. With the final phase of fracture repair, the osteoclasts remove the excess bony material, compact bone replaces primary bone, and it leaves typically a slight thickening of the bone. If it remodels, it comes back stronger. At least that's theoretically what should happen. And you can see a fracture repair here, the fracture hematoma here forming. The fibrocartilaginous soft callus then forms as it's improving here. Hard bony callus then forms, and then the bone is then remodeled. And it looks good as new, relatively speaking, potentially with a little bit thicker bone there as well in the area of injury, potentially. So what are the 4 basic steps in fracture repair? You should be able to answer and explain the risk of bearing weight on a bone when the fibrocartilage callus is forming. And that is Chapter 7 of the skeletal system.